Hello, my name is Zachary Rich, and I am a research training fellow in the Department of Internal Medicine. I'm excited to tell you about my poster on transitions from injection to respiratory opioid use in the fentanyl era. So some important background is there have been a lot of changes in the opioid crisis over the years to decades, whether this was switching from injection heroin use, the involvement of oral prescription opioids, or the saturation of the market with fentanyl. Perhaps one of the larger changes that has really happened very recently is the prevalence of smoking opioids compared to injecting them. A very short while ago, injecting opioids was by far the leading route of drug use involved in overdose deaths, and nowadays smoking is now the leading route of administration involved with overdose deaths. Historically, smoking had certainly been thought of as a harm reduction method for eliminating both opioid overdose deaths as well as injection site complications. Much of these harm reduction efforts were focused around injecting heroin, and nowadays, with fentanyl being the primary opioid in the market, less is known about the effectiveness and practice of using smoking as a harm reduction for decreasing opioid deaths. Previous studies have looked at this as well and found that people who are younger and have witnessed an overdose are more likely to be smoking opioids rather than injecting opioids. So our objectives for this study were to determine the trajectory of opioid use route of administration and how that's changed over the last couple of years. The second aim of the study was to use prospective data to describe characteristics of the most common route of administration changes. Specifically, we were hoping to evaluate if younger opioid users and those that have witnessed an overdose were more likely to make the switch from injecting opioids to smoking or sniffing opioids that was similar to other studies. Our hypothesis really was that there would be a lot of changing from injection to smoking and sniffing opioids, but relatively few individuals switching from smoking or sniffing to injecting opioids. And we were hypothesizing that similar to other studies, that younger patients and those who experienced an overdose during the study period were more likely to switch from exclusive injection opioids to a route that does not involve injection. So to do this, we performed a secondary analysis of the REBOOT trial. The REBOOT trial was a phase 3 randomized controlled trial that was conducted both in Boston as well as in San Francisco. And to be in this study, you had to have self-reported a non-fatal opioid overdose, as well as have ongoing opioid use. And really, we were hoping to look first at baseline characteristics and compare those that reported injection with every assessment with the study, and compare that with those that reported injection at the initial assessment, but then at a subsequent assessment reported that they were no longer injecting. In addition to baseline characteristics, we were also hoping to evaluate the relationship between events that happen between assessments and if these had a relation on someone switching from injection to a non-injection route using prospective data. So to do this, we first mapped out using a Sankey plot the route of administration for participants' first, second, and third assessments with the study. And here is the results for Boston, which shows a large amount of injection with some switching to nasal, but notably very little smoking of opioids there, which is interesting when comparing to San Francisco. And we see a lot more smoking and a lot more smoking plus injection co-use with a smaller amount of nasal as well. When we were looking at the baseline characteristics between those who were persistently injecting opioids throughout every assessment and those that switched at least once during the assessment, we didn't see any statistical differences among these baseline characteristics here. When we looked at age, race, ethnicity, education, employment status, or research site location. When we looked at events that occurred between assessments using pair-level characteristics, we were comparing those that here, comparing every single pair of assessments where the first assessment, the participant reported injecting, and then comparing whether on the second assessment they continued to inject opioids or whether they switched to another route or a safer route. And notably here, there was not an association between witnessing an overdose or experiencing an overdose and changing the route of opioid administration in between assessments. As we might expect, there was a difference between whether a participant had been in a residential treatment program, in a sober house, or attended an AA meeting or received counseling. So for me, I think the real take-home message here was neither experiencing a non-fatal overdose nor witnessing an overdose was associated with switching from injection to a safer route of consumption. I had thought before the study that if you had an experience such as either witnessing or experiencing an overdose yourself, that would perhaps prompt a change in behavior from switching from injection, which we typically think of as the route associated with the highest risk of overdose, to a safer route. I think there's many reasons for this, but I think it does underscore the difficulty facing a harm reduction approach with opioid use in the fentanyl era. These are my references. Thank you very much.